Hello, Mr. Smith. My name is Marty, and I'll be taking you for your CT scan.
Hi, Mr. Smith. I'm Katie, and I'll be taking you for your ultrasound guided biopsy.
Hey,
Hey, we need this biopsy to see what kind of tumor Mr. Smith has.
but we need this CT scan to see where the cancer is. Mr. Smith,
Mr. Smith! Um, I think
I think you're right. He's. I think we need to go tell someone.
Hello, everyone, and welcome back to Val and Mark's M2 show. I'm Mark.
And I'm Val. Today's episode is Diagnosing Dying, Prognosis 201. It sounds heavy, but stick with us, and there will be no surprise multiple choice questions at the end.
What we are talking about is one of the trickiest skills in medicine, knowing when doing more stops being good medicine and starts becoming harmful.
Let's start with a simple idea. People don't all die the same way. Some may die suddenly, some may have cancer with more predictable decline.
And some may not be so predictable. Organ failure gives us that classic pattern: admitted, better, discharged, back again, like a very unpleasant loyalty program.
And that progresses to severe frailty. The long, slow slide, less reserve, more dependence, more infections, more admissions, and eventually, no bounce back.
It's like the rubber ball losing air. Each bounce back, lower and lower until it just doesn't bounce. But why do we miss it?
I think physicians are generally optimistic. The data shows we often overestimate prognosis, especially when we've known a patient a long time.
Unfortunately, biology doesn't care how much we really like someone. And let's talk about the surprise question.
Would I be surprised if this patient died in the next 12 months?
If the answer is you wouldn't be surprised, you're not predicting death. You're acknowledging possibility. And that should change the plan. And what about the double surprise question?
Would I be surprised if this patient were still alive in a year?
If your answer is no to both of those questions, that's your cue. Waiting for certainty usually means waiting too long. There are also other handy tools that we can use.
For example, the SPICT tool, Supportive and Palliative Care Indicators. The SPICT helps us notice patterns: repeated, unplanned admissions, declining function and mobility, increased dependence on others, weight loss, and persistent symptoms.
It's not a label, it's a nudge. There's also the Palliative Performance Scale, or PPS.
And at a PPS of 40%, these patients need one or two people to assist them to get out of bed and mobilize. Half of these patients are alive at 30 days, and almost none at 1 year.
And at a PPS of 20%, people aren't dying because they aren't eating and drinking. They aren't eating and drinking because they're dying. Half are alive at 5 days.
And when patients are frail, either physically or cognitively frail, even potentially treatable issues like an infection or fracture can be that last straw that pushes them into their dying time. And comfort care may be the most appropriate care. So, what are the take homes?
Well, these tools don't predict the exact moment of death.
But they help us know when to shift. Stop doing more to start caring better. Before we order that test, that IV, that drug, we ask ourselves, is this going to make this patient's life better for the time they have left?
Sometimes the most skilled care is knowing when enough is enough.
Doing
Doing best
best by
by
doing
doing
less.
less.
Oh my God, we're bad at that.
Mr. Smith, I'm here to give you your antibiotic.